Good afternoon, everyone. Welcome to our webinar on dementia. My name is Amy Harris. I work for the State Unit on Aging, and I work in the Colorado Department of Human Services. I think I'm among many other colleagues who also work in CDHS, but other people who were invited include those who work for Adult Protective Services and the ombudsman and other folks who work with in the counties. So we have a big wide net of people participating here who serve Coloradans. And I thank you for your service and for taking this time to learn about dementia, not only for the sake of your clients, but also for the sake of your own health and your own family. I started working for the State Unit on Aging 4 years ago. And the reason why I started was because I was caregiving for my grandmother who had dementia. And I learned a lot in caring for her. And I've learned so much more since I started working for the State Unit on Aging. Um, Dementia is a disease that affects many of us quite personally. And I'm really glad that you're able to take out the time today to learn about this disease. I'm joined today by Kelly Osthoff with the Alzheimer's Association. She's the Senior Director of Programs for the Colorado chapter of the Alzheimer's Association. And Kelly and I also work together as colleagues on what is called the Alzheimer's Disease and Related Dementias Action Coalition, a long acronym that we refer to as ADDRDAC. And together we work on a couple of different work groups. And the whole purpose of the Alzheimer's Disease and Related Dementias Action Coalition is to implement the ADRD state plan. So Colorado unveiled a state plan to reduce the risk of dementia and to better support people living with dementia and their caregivers about 3 years ago. And one of the missions of the plan is to educate people far and wide across the state about dementia. So you are now a part of that implementation of this plan by being here today. So thank you for that. Um, Kelly will be presenting for the entirety of the presentation. Please know that the chat has been purposely disabled. However, if you have questions, please enter them in the Q&A box, the question and answer box, and then we will take questions at the end. You also are not able to unmute yourself, and that's on purpose just to make sure that the recording is one that will be really easily accessible and viewable by people after the fact. So you can just sit back, relax, enjoy the presentation, and if you have a question, be sure to use that Q&A box. I think that's all the housekeeping I can think of, so I'll pass it on to Kelly.
Yeah, thank you so much, Amy, for that welcome and introduction. Confirming before I get started that you can see my slides still. Great. Well, hello, everyone. My name is Kelly, and I am the Senior Director of Programs at the Alzheimer's Association of Colorado. And like Amy noted, I also sit on the work group to implement the Alzheimer's and Dementia State Plan through CDPHE. And if I were to kind of boil down how I am supporting that work and what our biggest focus is, it would be education, educating the general public, communities, professionals, and families on dementia, on Alzheimer's, and on what resources are available in this rather dynamic, ever-changing landscape that is the reality of Alzheimer's and dementia care. So in summary, in addition to my kind of daytime job with the Alzheimer's Association as our program director, I also chair what we call the E work group, which is a work group supporting the state plan to advance education. Really, that is what that E stands for. And Amy was so helpful in setting this up for you all at CDHS, because whether you're professionals who work with this population or you're curious on this topic, or possibly you as an individual have family or personal connection, this really is important information And as you probably noticed, it's probably why y'all are here today. This really is an increasingly important topic, and one that it is so critical that we address, but address together. Address in terms of connecting people to supports, but also offering this type of education so that we can advance Colorado, its systems, its communities, its organizations, to becoming more dementia capable, meaning capable to support this large group of people who are not only living with dementia, but one that we anticipate to grow pretty tremendously in future years. So moving along to start diving in to this topic. Honestly, even though this is an hour-and-a-half webinar, and I'll talk for about an hour and we'll have 30 minutes for questions, this is really a big topic to kind of crunch down to that time frame. And with that being said, please know that the Alzheimer's Association and those individuals and organizations who support the state plan, along with our public health department here in Colorado, we are here as a continued resource, because today really is just going to be the tip of the iceberg, if you will, in terms of information that there is to know about this topic. There's so much else out there, but today's presentation really had the intent to pull together some of the key things that everyone needs to know, regardless of where they're coming into this space from, or whether or not they've had a lot of experience with this, or they have. The topics today will be kind of the essentials, but please know there's so much more information out there. With that in mind, I always like to start by kind of painting a big picture to illustrate why this matters. Why is it important for all people to learn about dementia? And why is CDPHE and other organizations investing so much time in implementing the state plan and doing this work? And I think the data here demonstrates kind of why this matters. So there's some interesting statistics on the slide here that to me are the business case of why this is such an important topic, and that subsequent slides that I'll show will demonstrate why it will be even more important in future years. So we estimate at the Alzheimer's Association, through our annual facts and figures report, this is a very long document that has tons of great data in it, we estimate that nationally, there are over 7 million Americans living with Alzheimer's disease. And that is specifically unique to Alzheimer's, not other forms of dementia that I'll talk about in a minute. And don't worry, I will dive into what the difference between Alzheimer's and dementia is. But with that, we also know that almost 12 million Americans are providing some sort of unpaid care to someone with dementia. So these 12 million Americans are people who are not receiving payment for their care. They are friends, neighbors, family, chosen family to someone with Alzheimer's, and they are caring for them to keep them safe and well. So truly, this is a disease that not only impacts the person with it, but it's what I like to call a family system disease, and a disease that not only the person with it is living with it, but especially as the disease progresses and possibly the person with Alzheimer's isn't aware of their symptoms or maybe is in denial, the family system around that person is very aware. And so not only does this impact people living with this condition, but it so too impacts their social circle, their families and friends. We know that this is a very expensive disease. Not only is it expensive to the individuals, someone may have to retire early because of their Alzheimer's. They may have to pay for care and drain a savings retirement account that they had intended to use otherwise. And so it is very expensive on the individual level. Additionally, however, it's expensive on a national level, on a really large scale level. We know that in 2025, Alzheimer's disease alone cost the nation $384 billion. And if we do nothing to change the trajectory, the course of this disease, in 2050, Alzheimer's disease alone could cost the nation upwards of $1 trillion. And these are actual costs. So these are costs to Medicaid, Medicare, and other programs. This really doesn't even include the value of the care that our unpaid caregivers provide. And you can see here that if we were to value that care, it would be 19 billion hours that our unpaid caregivers provide, valued at $413 billion. So to me, this data demonstrates why this is such an important topic, not only for those who are facing it professionally, personally, both, but really is an important topic for our entire nation. When we look at that information and we boil it down even further to just Colorado, I'd like to present this data. This data to me is really interesting because it just is Colorado, but yet it is still rather staggering. So in Colorado, over age 65, we estimate that there are nearly 91,000 Coloradans living with Alzheimer's disease. And again, this is Alzheimer's disease. It's pulled from specific Alzheimer's diagnostic data and isn't necessarily inclusive of other dementia data. And I'll go into that in a minute. We also estimate, again, because as a family system condition that warrants many people's support of the person with Alzheimer's, we estimate that there's about 177 Coloradans here today serving as unpaid caregivers. Now, what's interesting to me as a gerontologist, that's my kind of background and education, is the study of aging and aging populations. What is interesting to me is that Colorado's older adult population, so those people age 65 and older, is expected to double by 2050. Now, 2050 feels like, at least to me, it feels very far into the future, right? That feels like way in the future. But in all reality, that's only 25 years away. So in 25 years, our older, over age 65 population is going to double. So with that being said, this is why CDPHE and organizations like the Alzheimer's Association have prioritized a variety of things, such as brain health and risk reduction, which I'll talk about today, caregiver support and education, which I'll also talk about today, and then just connecting people to resources, because we anticipate this population change and more people needing this infrastructure of services in future years. And additionally, when we look at the landscape of the workforce and the healthcare environment that we need to care for this large group of aging people, we know that there's a pretty significant shortage of providers and care professionals to care for this large population of people aging. So we estimate that to meet the need of this much larger group of older people in 2050, we'll have to see a pretty significant change to our workforce, specifically around medical specialists such as geriatricians and other care professionals. And if we're to meet the need that we're going to see in 2050, it would have to increase by almost more than 200%, pretty tremendous. Additionally, we see the same reality in direct caregivers. Even though in 2020, there was 36,890 direct caregivers, to meet the need in just 5 years, we're going to have to increase that population by 33%. And that is kind of one of the things that the work group of the state plan through CDPHE is working on, is addressing some of these workforce shortages. But I like to paint this picture because I think it boils down the message that we hear a lot, and it relates it to dementia and Alzheimer's in specific, and caregivers. So what I hear a lot, and I'm hearing this more and more, is the changing nature of Colorado's population. And this is true in many states, but especially in Colorado. Colorado has more older adults aging into our system. So we know nationally that if there's no change in course, meaning there's no treatment or preventative measure or risk reduction measure done, we know that the number of people living with Alzheimer's over age 65 will double by 2060. So in 35 years, all of those people living with Alzheimer's today and their caregivers, that number will double if there's nothing done through a public health lens and also a community caregiver resource lens. If nothing is done, that number will double. And so up here I have a really interesting graph that will show some of the population changes that I'm talking about. Age is the number one risk factor for Alzheimer's disease. So as people live longer and simultaneously as they might be managing other conditions that would have historically shortened their lifespan, we are seeing people live longer. And because of the population changes that we had 60, 70, 80 years ago, such as the baby boom, we are seeing more people, so larger groups of people living longer. And so because age is the main risk factor for Alzheimer's, we are anticipating larger groups of people experiencing Alzheimer's. And even in today's landscape, we have a shortage. We have workforce shortage, we have resource shortages. And so to meet that demand that we are expecting, there's a lot of work that has to be done on this topic. So this graph here, the purple, shows the change in population of people over age 85. The orange shows the change in the population in people over 75 to 84. And the turquoise represents the change that we anticipate in those people who are ages 65 to 74. So again, because age is the main risk factor of why people develop Alzheimer's disease, as we have larger groups of people living into their 70s and their 80s, we're therefore expecting larger groups of people to develop dementia and Alzheimer's. And that is if no change of course happens. So if there's no intervention, such as a treatment or risk reduction. But even with this change in population, it is still important because we will also have to support these people as they grow older. So moving on from kind of that epidemiological kind of big picture perspective that I think justifies our conversation today, I always like to talk a bit about risk factors. Why certain older adults develop Alzheimer's and others do not. In the past, there has been a misunderstanding, a rather big misconception that all older people, all people over age 65 have dementia, have Alzheimer's. And that is just not true. As the medical and scientific community has studied Alzheimer's more, and as we have understood aging populations better, we know that Alzheimer's and dementia is not considered a normal, expected, typical part of aging. Age alone is not a reason why someone develops Alzheimer's or dementia. However, it is a risk factor. So after age 65, risk continues to go up for Alzheimer's. However, after age, there is a pretty significant impact of family history and genetics. Many times when people learn that I work for the Alzheimer's Association, they will say, well, there's no Alzheimer's in my family, so I'm good. Or I haven't had that impact my family yet, so we're kind of in the clear. And while family history and genetics certainly increase risk, people without Alzheimer's in their family or without some of the genetic markers that we know about can still develop Alzheimer's. So really, this is a condition that all of us are susceptible to getting in later life because age is the main and number one risk factor. It's really important, I think, in any public health work, but especially as it relates to Alzheimer's and dementia, to take a public health lens. That includes a health equity focus. So when we not only look at this population, but we do so through this health equity lens, we know that there are certain populations that have a higher incidence than other populations. So if we are just to look at the over age 65 population, so take everyone over age 65, we kind of guesstimate that 1 in 9 over age 65 has some form of dementia. When we look at that number over age 85, the prevalence really is 1 in 2, 1 in 3. Now that's the general population, but it's important to note that there are certain communities, certain populations that carry a higher burden of Alzheimer's disease prevalence. In fact, Black Americans, African Americans, are twice as likely as white Americans to develop Alzheimer's. Hispanic Americans are 1.5 times as likely. And 2/3 of everyone living with Alzheimer's are women. So this disease, certainly it is something that can impact everyone in the general population, but it is important to note that there are higher prevalence numbers in communities of color and within women. And for years it was thought, well, women live longer, and so that's why. But what the science and the research is finding is that might not necessarily be true. There might be some other factors as to why women have a higher likelihood of developing Alzheimer's disease. So there's a lot of research happening as it relates to Alzheimer's and dementia. And that is actually one of the main, but not only, but one of the main focuses of the Alzheimer's Association is to not only fund research, but convene researchers to share knowledge, share findings to advance the field. And there's some research being done to look at why is it that women develop Alzheimer's at higher rates? Is it different education experiences across the lifespan? Is it hormonal differences? Is it access to opportunities across the lifespan? And so additionally, the same work is being done in communities of color, research being done to look at why is it that Hispanic, Latino Americans, and Black African Americans have higher prevalence of Alzheimer's. And an interesting finding a few years ago came out that really, I think, emphasized this concept of social determinants of health. Social determinants of health are realities, things that we are exposed to or that are characteristics of our life from birth to death to change how we grow older. And so the social determinants of health is a really important conversation when we look at why certain communities are impacted. And so things like preventative health, access to education, access to good food and nutrition, exercise and physical activity opportunities early in life, things like that from birth to death impact and influence how we get older, how we age. So this is, I think, another reason why some of you might be working in the aging space. You might be working in a space that primarily supports older adults. Some of you might be working primarily with children. However, I would argue that this conversation matters to us all because there are things in our healthcare from birth to death, those social determinants of health that I talked about that influence and impact how we as individuals and how populations grow older. One study that comes to mind is that I think it was maybe back in like 2023, 22, that found that racism and experiencing the hardship of that throughout the life can cause enough trauma that it actually impacts how people age. So there's a lot of interesting research going on, and frankly, that could be a whole other arm of this presentation itself. But I think that's important for you all to understand what work is being done to better get a picture of why some older adults develop dementia and others do not. An important part of this conversation that we haven't touched on yet is our younger onset population. What I mean by younger onset is when symptoms, and I'll kind of clarify that term in a minute, but when symptoms like memory loss, changes in reasoning, issues with planning and organizing, changes in mood and personality, when those dementia symptoms start to happen prior age 65. So many people have associated Alzheimer's only with older adults. And while people older than age 65 do comprise the majority of people living with Alzheimer's, it is important to note that there is a younger onset kind of cohort as well. So we refer to younger onset Alzheimer's when symptoms start before age 65. It's much less common, but it is a reality that a small group of people face. And we know that their experience through Alzheimer's can be particularly challenging. It can be very challenging for people with younger onset to get a diagnosis, because I've worked with people who their physicians, they've brought their concerns about their cognition, their memory, their thinking and learning skills to their doctor. And if they're under age 65, the doctor has said, well, it's stress from work, or maybe you're not sleeping well, or maybe it's depression. And so it can actually take younger people a longer time to get a diagnosis because of some of those assumptions that we're working to address in the medical community. So it can be more challenging for them to get a diagnosis. But then on top of this, it can be challenging to navigate this disease because oftentimes people with younger onset have young children. They have children in middle, high school, younger. Maybe they're at the height of their career and they were expecting to retire yet. So possibly their financial health is not where they thought it would be. And while there are a few social programs that some of you may work on that help people who have younger onset Alzheimer's, it can be a really uniquely challenging experience. So that's just kind of as we talk about certain populations, certain communities of people who experience this disease differently, that's a really important one. Now, so far, I probably have been, you're probably wondering this, is what is the difference between Alzheimer's and dementia? These terms often are used interchangeably. However, their differences is very important. So understanding how these terms are different is kind of an important concept to get as you pursue dementia education. Dementia is an umbrella term, so it's kind of, think of it as a catch-all of changes in someone's cognition. So our brain is our cognitive organ, and our brain does very advanced things and very simple things. We do things like we remember what has happened in the short term. We remember what's happened in the long term. We can think, we can plan, we can organize, we can follow instructions, we can make sense of information. And when someone experiences changes in those abilities significantly enough where their daily life is impacted, those are symptoms of dementia. And dementia does not just happen with age. Not all older people have dementia, even though that is how historically people have thought about it, that every older person is supposed to have dementia. There's no underlying cause other than age. And what the research is showing us is that actually there are a variety of causes to dementia. And while age is a risk factor, it's not a direct cause. Alzheimer's disease is a disease of the brain. So it is actually what's happening inside the brain that is the number one cause of dementia. So Alzheimer's disease is represented by unique plaques, unique tangles that develop in the brain, and it causes about 60 to 80% of all dementia. I think because it's the most common cause, that's one of the main reasons why these terms are so interchangeably used. But what I like to tell people is Alzheimer's disease is what is happening in the brain. It's this buildup of amyloid plaques and tau tangles. That is the unique characteristic of Alzheimer's disease. Dementia are the symptoms, the changes that as a family member you're observing in someone. There are other causes to dementia in addition to Alzheimer's. So we estimate that Alzheimer's causes dementia about 60 to 80% of the time. So Alzheimer's is what's happening in the brain, and 60 to 80% of the time, that is the culprit of what's causing dementia. However, there are other causes to dementia that include vascular dementia, dementia with Lewy body, frontotemporal dementia, other forms that include other diseases, conditions, and then mixed dementia, where the dementia might be caused by a variety of these things. And each of these diseases have their own pathological, biological presence, whereas with Alzheimer's, it's those plaques and tangles. The other causes to dementia look differently in the brain, and they impact different parts of the brain. And therefore, their symptoms look a little bit different. So dementia with Lewy body, for example, has a somewhat different kind of pathological, biological presence in the brain, and it starts and impacts different parts of the brain than Alzheimer's. So while someone with Alzheimer's disease in the very early stages primarily sees short-term memory loss as their primary symptom, someone with dementia with Lewy bodies may not experience short-term memory loss as significantly. They might have other symptoms like paranoia, hallucinations are rather significant with dementia with Lewy bodies, and then sleep disturbances. Additionally, frontotemporal dementia impacts the front of the brain that is primarily responsible for judgment and decision making. So someone in the very early stages of what we call FTD, their main symptom may be poor decision making, bad choices, bad judgment, and they might not experience memory loss until later on. So I say all this because if someone receives a diagnosis of dementia, that is not a full picture of what's going on from a health perspective. A question that would then follow would be, what is causing that dementia? Because Alzheimer's disease progresses and looks differently than frontotemporal dementia. And there are treatments for Alzheimer's that might not be appropriate for some of the other causes to dementia. And so we are entering this space that while in the past, many people have just been told that they have dementia, we're entering into the space where the next question should be, what is causing it? And that is important not only so someone can access the proper treatment and plan appropriately for the symptoms that we can expect, but it is also important because there are things that can happen in the lives of older people that can cause them to have some changes that look like dementia, but they're really not. So things like vitamin deficiency, poor sleep, untreated sleep apnea, alcohol abuse, untreated depression, all of these different things can happen. And when they happen in later life, for some people, it can affect cognition enough where you'd want to know, well, actually, what's causing these cognitive changes? Because if it is one of these things over here that can be fixed or treated or otherwise manipulated, we'd want to go down that road. But if not, we want to know what to plan for and prepare for in terms of actually what's causing the dementia. So in short, Alzheimer's is a brain disease, so it's actually what is going on in the brain that causes changes primarily at first in short-term memory loss, which then causes changes in thinking and behavior. And that behavioral piece is huge because people with dementia, because the disease is impacting a part of their brain, likely will see pretty significant behavior changes. So they might become rather irritable when they've otherwise been rather cool and complacent. However, the reverse can happen. Someone can be a little feisty, but then they can just become kind of chilled out and unattached when they have Alzheimer's. So there is that behavioral change. And then on top of that, in addition to that short-term memory loss that might present itself in asking the same question over and over again, telling a story repeatedly, that thinking and learning change is important because this can kind of be hard to catch because someone might start to struggle to do things that they once enjoyed, and that represents kind of their changes in their thinking. So someone who maybe previously could fix and change a tire might start to struggle with that. And likewise, someone who could follow a recipe might start to struggle with that. So that kind of represents those changes in thinking and reasoning. Over time, however, as this disease progresses throughout the brain, even though it starts in that part of the brain that is responsible for short-term memory, as this disease progresses, nearly every cognitive ability is affected. And eventually, because of these changes, someone will need around the clock 24/7 care to be safe and healthy and taken care of. And so because this is a progressive disease, and because the middle to late stages take away so many abilities of what people can do for themselves, that is when things start to fall to the caregiver and why this affects so many people, not just with the person with it. So eventually it is important for people to understand that someone eventually with Alzheimer's might need 24/7 around the clock care. And that might be delivered in the home, or that might be delivered in the community at a care community. I find this rather fascinating and a very interesting thing to talk about when I do this kind of disease education. Here on the screen, we have illustrations of two brains. The brain on my left, I'm not sure for you all, but the brain on my left is a normal brain. So a brain that has not had any atrophy or shrinking or cell death. And then the brain on the right represents what a brain looks like after having Alzheimer's disease progress throughout it. So Alzheimer's disease, while it might start in a particular part of the brain, that at first someone might just be a little slower. They might just be, it affects the part of the brain that is responsible for word retrieval, that filing cabinet of words. So at first, because it's just affecting the neurons in that part of the brain, they might be a little slower to respond. Might take a little bit longer to open that filing cabinet. They might be clever enough to come up with another word to replace the word they're looking for. So if they can't think of spoon, they might think of thingamajig over there that's black. And so early on, someone might be able to compensate. But as the disease progresses, so as these amyloid plaque and tau tangle proteins start to impact the brain and then progress throughout the brain, we start to actually see not only disturbance in those brain cells that might just cause a delay, we start to see actual neuron death, unfortunately, and then brain atrophy, so shrinking of the brain. I think that this is, and it can be a very medical description of this disease, but to me, it is an important one because At the Alzheimer's Association, we do a lot of one-to-one helping with caregivers. So people who call, we have a 24/7 helpline. It's available day, night, English, Spanish, holidays. There's always master's level clinicians working on it. Probably some of the most common calls we get are around communication and behaviors. Someone is repeating themselves just constantly and it's becoming unbearable, or they are exhibiting behaviors like paranoia and suspicion that just don't make sense, such as someone is stealing my mail. And so that's a lot of what our helpline does, is that one-to-one helping and education. To me, this is a very visual representation of what's happening physically to allow caregivers to understand what their person is going through. So over the years, people I've talked to people who have called their helpline who have said, my spouse has repeated the same question over and over again, day after day, and I have told them the answer. And they often say, how can I get this to stop? And what I like to say is, I understand that that can be really frustrating for you, hearing the same story, question, what have you, over and over again. But let's think about what is happening in the brain. Those neurons, those brain cells, those areas that store memory and are responsible for sending messages to the rest of the brain are either very early impacted or they actually might just be gone. And so that ability to create that memory is no longer there. So to me, this drawing, this illustration represents, I think, a description of the disease that allows for some empathy into what's going on with people who have Alzheimer's. We might be frustrated by the repetition. It can be incredibly frustrated, but this, I think, paints the picture as to why we can't expect them to remember that they've already told us that. Because the part of the brain responsible for memory is unfortunately gone in mid to late stage Alzheimer's. Currently, where the medical and scientific research is looking is to really understand the progression of this disease. When does it start? How does it progress? How do we talk about it as a progressive disease? What is interesting to me is that with Alzheimer's disease, the medical and scientific community have found and identified that the disease is present in the brain 20 years or more before symptoms occur. So let's kind of unpack that a little bit. So the disease is present in the brain, meaning those plaques and tangles that are the kind of hallmark characteristics of Alzheimer's, those plaques and tangles start to build up at abnormal levels in the brain 20 years before someone starts to show the symptoms of impairment. This kind of understanding of the disease is going to drastically change how medical care is delivered, but also, I think, how we work with older adults. Because in recent years, we have been supporting people with dementia kind of in these middle to later stages. The symptoms of the disease were so obvious, so pronounced, that often we have been kind of helping this group of people reactively. Something has happened, such as someone getting lost in their car or on foot, that has caused some sort of issue or crisis, and then they've been plugged into this ecosystem of social services. Because the symptoms were so pronounced, something happened. Because of the changes in diagnostics, so people are able to be diagnosed earlier, the aging profession is going to see more people in the earlier stages, even early stage, but also mild cognitive impairment due to Alzheimer's. And from a public health kind of risk reduction perspective, because there is this asymptomatic time frame where we know and can detect disease in the brain, but someone is functioning otherwise cognitively normal, there's going to be more prevention, medicine, and also lifestyle prevention. What can we do to not develop symptoms like this in later life? So this is a really rapidly changing area of the Alzheimer's and other dementia medical and scientific realm, because we're going to see people not only diagnosed sooner, but we're also going to have a conversation as a general public about brain health. What are things that we can do earlier in life to take care of our brain and possibly either delay those symptoms or possibly not get them at all? So thinking of Alzheimer's as a continuum is really, I think, going in the next 5 years, going to like revolutionize, drastically change the aging landscape, social services landscape. And frankly, it's going to diagnose people earlier, but hopefully the diagnostic experience is going to be easier and less burdensome for the people with the disease. Now, to summarize, I always like to talk through the 10 warning signs of Alzheimer's. And these are important because these are those early changes, those early symptoms that some people might think, well, those are just normal age-related changes. Someone in their 80s is supposed to do these things. So education around these early warning signs is really important, because we have thought for years that Alzheimer's is short-term memory loss. And yes, that is true. But it also includes other things like challenges in planning or solving problems, difficulty completing familiar tasks. So I talked about the example of maybe struggling to follow a recipe, confusion with time or place. So possibly pulling up to someone's home that they have lived in for decades and someone saying, oh, this is a really cute home. I wonder who lives here. Not recognizing that they live there. So confusion with time or place and what things are. Trouble understanding visual images and spatial relationships. New problems with word and speaking and writing. So struggling with that word retrieval. Misplacing things and losing the ability to retrace steps. So this is kind of, I think, speaks to navigation. Decreased or poor judgment, withdrawal from work or social activities, and then changes in mood or personality. I think anyone with a cognitive organ, so anyone with a brain, probably looks at these 10 signs and thinks, oh, I had 4 of those last week. And so what I like to say here is we all have different function levels of our brain, right? We sleep well one night, we don't sleep well the next. We're stressed at times, we're not stressed at times. So our brain, I at least know mine does, works better on some days. And as people get older, they do see and experience possibly some delay or maybe slowness in their cognitive functioning. But the difference would be, and when it can be considered a symptom of dementia, is when those symptoms are so pronounced that not only can the person not recognize that they had them, they're often unable to recover from those changes. So I'll give you an example. I might forget someone's name. I likely can recover from that memory lapse. I can pull up my phone, I can see what that person's name is. I also remember that I had that memory lapse. So not only was I able to recover from it, but I was able to remember that it happened. Dementia symptoms are when these things, some or all, are happening so frequently that someone is unable to function in the sense of remember that those things happened or recover from them. Another takeaway, I think, from this list is that, yes, short-term memory loss is a component of Alzheimer's, but there are other symptoms as well that sometimes are hard to detect as a symptom of the disease. So often caregivers will say, my mom is more paranoid, more suspicious than ever before. Is that associated with Alzheimer's? And the short answer is yes. because of the short-term memory loss and because of the other changes that are happening, someone may become excessively paranoid or suspicious, and which I think kind of is covered under those changes in mood, personality. And so memory loss is a primary symptom of Alzheimer's. It is so much more than that. And what interests me is that Alzheimer's actually can change someone's ability to physically get around, so their ability to walk and understand the world around them. And it also can affect someone's vision and just kind of their experience in the world. So it's important to understand that, yes, memory loss is a primary part of Alzheimer's. It's not the only change. I talked about that we are really entering this kind of new landscape of brain health, of Alzheimer's and dementia care. And I also mentioned, when I kind of gave that example of the continuum, that historically people would receive a diagnosis in that middle to late stage because it was so obvious. So I know with my own grandmother, she always made coffee. She always used a coffee maker. And we started to notice that she would take her coffee grounds, and instead of using her coffee maker, she would try to dissolve them as if they were instant coffee grounds. And unfortunately, she would then drink that slush of coffee grounds and water. But what it told us is that she is struggling with this process of using her coffee maker. Then it became her super paranoid that people were spying on her and that there were people in her home. And what we had to realize then was we did take that seriously. That was a safety hazard. So we investigated what could be happening. And we kind of deducted that the pictures on the walls and then the mirrors that she was seeing her reflection, she was unable to detect who those people were, even if it was herself. And so with that, we realized, okay, whoa, something is definitely going on. Now, those are pretty moderate symptoms. It was pretty progressed into her disease and into her dementia. And at that point, she did receive an Alzheimer's diagnosis, but it was very clear that that is what was going on because it was so clear that those were the symptoms she's happening. In today's landscape, because of advancements that are happening in research, some of them are still in clinical trials, but others are starting to be adopted in clinical practice. This disease is one that will be diagnosed sooner and sooner. So we are not telling people to wait until there's a crisis or symptoms are so obvious to talk to their doctor about brain health because of two things. First, there is better diagnostics. The medical community knows about this disease better, and there are better diagnostic tools where people are and can be diagnosed earlier. And then there are also changing treatments that people can benefit from. And so that is incentivizing people to talk about this with their physician earlier, not just waiting for a number of odd things to happen to then go talk to the doctor. So it's important when we look at those warning signs that if someone is concerned about themselves or another, it is important to document those things. Someone can experience one or many of these signs. And it is really important for people to talk to their doctor about their brain health, meaning how is their cognition working? So the first step is if someone is concerned about themselves or a loved one or a client and they're exhibiting these warning signs, it is really important sooner than later to talk with a doctor and hopefully experience what we're calling early detection. So this is another focus of the state plan work group through CDPHE that Amy and I have talked on, is not only are we working to raise awareness about these early warning signs, and not only are we working to address some of those workforce issues I talked about, a big part of our public health work around Alzheimer's is to drive early detection, to encourage people to talk to their doctor sooner than later about their brain health, even if they don't exhibit any symptoms, but especially if they are exhibiting memory loss and some of those other warning signs. Talking to someone's doctor sooner than later is critically important. In the past, there has been a lot of this kind of assumption of, well, there's nothing my doctor can do for me, so what's the point? Or I'm terrified of an Alzheimer's diagnosis, so I just don't want to talk to my doctor about it. But this is really a new frontier of Alzheimer's and dementia care. And there's a lot of benefits for this early detection, and it's why the state plan group is focusing on this topic so much, is because it allows for people to plan for their future. It also allows them to explore new treatment options. There are new treatments, and I'm talking in the last 6 months, there are new treatments that can benefit people in this very early stage that aren't going to provide as much benefit in those later stages. So an early detection and diagnosis allows people to explore treatment options or participate in clinical studies because there's a lot of work going on in there. It also allows the person with dementia in as early as possible, when their cognition is as intact as possible, to participate in their care planning and to participate in their decision making. I know that through my work, I have often worked with families where there's no legal documents in place, there's no documented choices, and you might have a group of adult children trying to make decisions on behalf of a parent, and they're uncertain what that person would have wanted because the dementia has become so progressed that the person doesn't have capacity to participate in those decisions. So this earlier diagnosis gives a better window for that as well. This is one of the areas that is rapidly changing in terms of Alzheimer's care, and that is related to evaluation and assessment and diagnosis. So I've been talking about, and I even gave the example of my grandmother, of the reality that people waited to kind of those middle to late stages when it was so obvious, maybe there was some sort of crisis or something happened that was weird enough that it was quite obvious what was going on, to get a diagnosis. And at that time, based on what was happening, a physician could say, yeah, this looks like Alzheimer's, this feels like Alzheimer's. And even before that, and people sometimes still think this is true, there was a time when Alzheimer's could only be diagnosed at autopsy. And that is no longer the reality in which we're working. In fact, because the medical community has understood this disease better, they know the early symptoms, just based on symptoms, Alzheimer's disease can be diagnosed in current life. That is kind of a misnomer that's out there. And what that looks like is anyone over age 65 who is insured by Medicare. I use the example of 65 because that's generally when people go on Medicare, when we think as a society, when that kind of transition happens. Medicare covers an annual wellness visit, and at that visit, it covers a cognitive assessment. What that means is it's a very simple, basic assessment screening tool that can be given verbally, through writing, that essentially assesses someone's cognition. And we are encouraging people to, in taking charge of their brain health, request this screening and evaluation tool earlier. So that's another focus of our work group through CDPHE, is early detection, but doing a lot of patient education and advocacy to empower people to even request them for themselves if they're not given it at the doctor. What that general screening will do is it will detect some sort of impairment. Now, that should not be the last step in the process. Unfortunately, in the past, for many people, that has been the last step in the process. oh, you've done this assessment, you've done this screening, and there is some impairment, and this person has mild to moderate dementia, for example. Now the question should be, well, what's causing those changes to happen? What is it that is causing that cognitive impairment to happen? Because could it be something like medication interactions where we address the medication and maybe someone's function gets a little bit better? Or is it one of those dementias that we talked about, such as frontotemporal dementia, Lewy body, Alzheimer's, etc.? And so a physician may screen for depression because unmanaged depression in older adults and as a population, that group experiences higher levels of isolation, depression. So there might be a screening for depression because that untreated depression can fog someone's brain enough where they could exhibit the signs. There might be an interview with a close companion because, as we all know, we're with our doctors for like 15 minutes, and that might not be enough time to cover that. So a physician might want to have information from a trusted and well-known family or friend, documenting what changes are happening and the frequency at which they're happening. So that's what I often tell people who might be worried about a friend, a neighbor, a family member. The best thing is that documentation of how often are these things happening and how are they impacting someone. After that, there might be a number of different tests. Blood tests, brain imaging like MRI and CAT scan. But this is where the diagnostic process is changing. We've been talking a lot about like historically kind of further along, but in recent history, maybe in the past few years, in clinical care, so not in clinical trials and clinical studies, this is in the general clinical setting. So it has moved through clinical trials into the general clinic setting. There has been the use of cerebrospinal fluid analysis, a spinal tap, that can detect elevated levels of those amyloid plaques and tau tangles in the body. Then there were advancements in PET scan technology. So PET scans aren't new. What is somewhat newer in kind of the general public is their use in Alzheimer's diagnosis. So an MRI, it can detect some things with the brain. It does not detect disease. A PET scan does detect and can show those amyloid plaques and tau tangles that I talked about. Probably 9 months ago, I don't know, 6 months ago, there was a big news story that the first blood test for Alzheimer's was released. And that was a really kind of milestone moment in Alzheimer's disease care because a PET scan, while it detects disease, is very hard to scale. There are many rural communities, frontier communities, mountain communities that might not have access to a PET scan. And so something as simple as a blood test, a blood draw and the analysis of that blood is going to really expedite and scale our, as a community, kind of diagnostic ability. And so I would say the medical community, I think, is still figuring out the kinks of this blood test, you know, adapting and equipping primary care physicians, training them how to use it. Is insurance going to cover it, etc.? Those conversations, I think, are all happening. But what this represents is a very monumentous time where people with Alzheimer's are going to be able to be diagnosed earlier and easier. Parallel to those advancements in diagnostics that I talked about, there have been advancements in treatments. So Alzheimer's disease was discovered in the early 1900s by Dr. Alois Alzheimer. And it wasn't until the 1980s, so 80 years later, that there was any form of treatment, pharmaceutical treatment, for Alzheimer's disease. These treatments were primarily symptom management. So the disease was still progressing, someone was still progressing with the disease, but their intent was to maybe help with some of the symptoms. In 2022, 2023, the first disease modifying treatment hit the market. And while that treatment, it was called Aduhelm or aducanumab, has been taken off the market, there's a number of other new treatments that slow the disease progression in its earliest stages that are available to the general public. I won't go into naming them, but in simple terms of what they do, when taken early enough, because someone has had a PET scan to confirm that they have amyloid plaque in their brain, what these treatments are doing, and you'll be hearing a lot more about these, is removing that amyloid plaque from the brain. In a few months, a year, there's going to be more treatments than ever before to benefit people, to give them more cognitively better years in that early window. And so this is one of the most dynamic spaces when we look at aging, is the advancements in diagnostics and treatments as it relates to Alzheimer's. We've historically just helped people once they hit to those middle to later stages, and it was a discussion of protection. How do we kind of keep someone safe? Now we are moving into a much different conversation of diagnosing earlier and hopefully being able to give people more cognitive years in that window. I want to touch briefly on the impact on caregivers, because that was a pretty kind of thorough overview of the disease. And even with that earlier diagnostic ability of Alzheimer's, under the notion that more people are thus going to be diagnosed, people will still need to serve as caregivers. So the caregiver component is still a really important part of the conversation. The data shows that about 2/3 of unpaid caregivers are women, 1/3 of dementia caregivers are daughters. And something that interests me, and I don't think it's shown on the slide here, is that nearly 2/3 of dementia caregivers are under age 65. At one time, I do believe that when we think of dementia or Alzheimer's, we thought of it a condition of just older people. And that included caregivers. It was an older person caring for a spouse, for example. The data shows, however, that the large majority, about 2/3 of caregivers, are under age 65, still working, raising young children. And so to me, yes, this is an important topic for those who might work in the aging programs across Colorado. But this is also, I think, why this matters to younger populations too. Because just because someone is in high school doesn't mean that they are exempt from the realities of Alzheimer's. In fact, we are seeing more and more younger caregivers. And we know that when we compare caregivers of someone with dementia to caregivers of other conditions, while those conditions are certainly very challenging to care for, the data shows that that twice as many caregivers of those with dementia indicate much higher emotional, financial, physical toll. They have twice the out-of-pocket costs, a very high prevalence in population of depression, elevated levels of anxiety, and then on top of that, just the overall expense of the disease. People who are caring to someone with dementia, who are serving as unpaid caregivers, are often susceptible to greater levels of stress, but also health conditions, especially in comparison even to the person with Alzheimer's. In the past, you may have heard a lot of people say, statistically, the people with Alzheimer's outlive the caregiver because caregiving alone can be so challenging. And that is a reality. So it's really important to recognize the signs of caregiver stress, which I have outlined here. Denial about the disease, anger, or irritability, the caregiver themselves withdrawing from friends and activities they once enjoyed, new levels of anxiety or depression, sleeplessness or exhaustion for themselves. I would say this is particularly true if the caregiver is wanting to keep their loved one at home and they are doing that 24/7 care. They're probably not getting a lot of sleep. They might experience lack of concentration or other problems that take either a mental or physical toll. The state plan work group, what Amy called the ADDER-DAC through CDPHE, is also working to address caregiver challenges and caregiver stress. And while there's a ton of other things I could talk about what we're doing to address kind of the issue of caregiver stress, I have to highlight our helpline. I talked about it earlier. The Alzheimer's Association has a 24/7 helpline, so someone will answer. I'm just looking ahead into November, the morning of Thanksgiving. Someone will answer. They will be a master's level clinician who speaks English or Spanish to offer one-on-one support around dementia-related issues. So our helpline can be and should be a backbone of support to dementia caregivers. Additionally, it's important for caregivers to take care of themselves and take a break. And this is one of the reasons why, as a coalition, we're working with partner organizations to promote respite programs, either respite funding or enhancing access to respite by increasing the number of providers, for example. Now that we've kind of moved through some disease education, we've talked about advancements in diagnostics and treatment. I also want to bring up this conversation of brain health. Yes, a lot of the research is looking at what are better tools for diagnosis and treatment, but research is also looking at brain health. What are things that we do from birth to death, either as individuals or as populations, that impact how our brain and thus how our cognition grows older? And studies have shown that there are actions that we can take at any point in our 70s, in our 20s, in our 40s to improve our brain health, meaning there are things we can do to help our brain function better in later life. There was some results that came from a study maybe 3 years ago, 2 or 3 years ago, that said around 40% of all dementia was preventable. That if people implemented these things, we would have seen much less dementia. And so the message here is healthy living is important for all of us. Whether or not we have known someone with Alzheimer's or dementia, we might be younger, we can do things that lower our risk of dementia. Now, there are some messages out there that there are products or things that someone can pay for that will completely guarantee that they won't get Alzheimer's, that they can pay this and they won't get dementia. At this point, if it sounds too good to be true, that is too good to be true. We're not in this conversation of complete prevention yet, but we are in this conversation of risk reduction. And so the Alzheimer's Association has created these 10 healthy habits for our brain. These are the healthy living points that CDPHE is promoting. And it is important to implement as many as possible, not just one. So while I wish it could be as simple as stay in school, challenge your mind, I wish that could just be it. That if I do crossword puzzles, I'm good. What the research is really showing us is it really is a combination of these things. So not only do we want to challenge our mind, stay in school, stay connected, but we want to eat right. We want to manage our diabetes, maintain a healthy weight, get enough sleep, protect our head, avoid head injury. To me, that's why this impacts and influences the lives of children, right? The use of helmets early on is so important. Refrain from smoking, of course, controlling blood pressure, and then get moving. Physical exercise is one of the best things we can do for our brain. To kind of wrap us up, I mentioned our helpline. Another thing that the Alzheimer's Association does and can do is we offer support groups for people with dementia and their caregivers. That peer-to-peer learning is so critical in this journey. We also offer tons of education programs. This talk was a little bit of a variety of things. We called it everything you need to know. But we have specific caregiving courses, for example, that dive into behaviors. We have a financial management program. We have a communication class, tons of really great resources. Trial Match to connect to research and clinical trials opportunities. I've included a few websites on here. I'll share the slides with you all. These are some really, really rich resources. But I'm going to kind of breeze through these. But please know that the work that's being done, stewarded by CDPHE, but supported by folks like Amy, a number of other folks who work for the state, who work for organizations in the community, like I do at the Alzheimer's Association. We are trying to tackle this topic from a variety of different perspectives. I am mostly involved in this this empower and engage. It really should be education. How do we educate the public on this topic? We're also looking at policies, what policy can change to do a variety of things, improve the experience from birth to death for people, but specifically dementia. We're looking at it from a workforce perspective. Not only is there enough workforce, is there enough workforce in the medical sense, but also the care sense that people will eventually need. And then, of course, monitoring and data collection. If you are interested in, I'll say taking this on the road. If you want dementia education for your company, your faith community, your what have you, this is one of the main focuses of the state plan work group, is going out to offer this education that is not only on dementia, but then also brain health. There was a large public awareness campaign that the state did. And then we're also looking to improve access to services and supports, not just offer this disease education. How do we connect people to things like education, respite, support groups, etc.? There's a few ways that I ask for your help today. If you'd like to host me or another one of our dementia educators at another group, we would love to do that. We would love to deliver this presentation or one of our subsequent, maybe more in-depth programs. You can help lead. You can become a dementia educator for the state, or you can just help spread the word. Hey, maybe your agency has a newsletter. We can include some information in that newsletter. So thank you for listening, and thank you for kind of going through all of that with me. And thank you for allowing me to end with this kind of ask, but it is really the intent of our work group through CDPHE is to not only touch one group like we did today together, but how do we expand then that reach to new audiences? Because you may think, oh yeah, I know a lot about dementia. And as I've talked about today, it's rapidly changing. Or there might be people who don't know anything who need to know. So thank you, Amy. The floor is yours. Hopefully we have some questions.
Thank you so much, Kelly. I'll let you take just a brief water break. You just did a lot of talking over the past more than an hour. Thank you so much for that rich information. We do have a couple of questions and we do have a few minutes left. We'll wrap up at 2:30, but we have enough time for at least a couple. So if there are any other questions, feel free to add them in the Q&A. The first question is, I think for the Alzheimer's Association, but could also be a broader question, which is, are there any caregiver support groups held in Spanish?
Oh, great question. Not at the moment. However, we're hoping I'm kind of stewarding this with a few other partners. We're hoping that there is something at least virtual by early 2026 that is hosted from someone in Colorado. Now, someone could go to our website and CDPHE's website and get information in Spanish, and our helpline is available in Spanish, and there are virtual groups in Spanish hosted elsewhere in the country. But from us here in Colorado, at least virtual, early 2026.
Awesome. Thank you, Kelly. The second question is that it's well known that alcohol consumption plays a role in dementia. What data is available to show the connection between cannabis and dementia? And Phyllis's experience, she finds that many older adults are consuming cannabis and is worried about if there might be a connection between cannabis use and dementia.
Yeah, so great question. First point, heavy alcohol use, yes, has been shown not to be for great health, brain health. Second, there is a cause of dementia called Korsakoff syndrome, which is caused by alcohol abuse that then causes someone to have lower thiamine levels. On Wednesday of this week, we are actually having a webinar and we're having someone come to speak on Korsakoff syndrome. So Amy, I'm going to send information on that for you. The second part of the question as it relates to cannabis, the Alzheimer's Association is really like evidence scientific based. And so we will not make claims or promote information until there is a really, really large evidence base. So what I would say on the topic of cannabis, which I think is more commonly brought up for us here in Colorado, is that a lot of research is currently happening on the use of cannabis from a risk perspective. So what does cannabis do to the brain in terms of increasing our risk? Research is also happening to explore cannabis as possibly an intervention to help with symptoms. Jury is still out on either topic, but it's ongoing. But we don't have enough definitive information to make claims on either side.
Thank you. The next question is wondering if this presentation could be available in Spanish, maybe, or if I'll add on to the question, could it be that a champion could emerge who would be able to give this presentation in Spanish?
Yes and yes. So we do have the ability to host this live in Spanish. So I have a few team members who can deliver this in Spanish. And if you speak Spanish, let's connect because that is one of the things that we are looking for are these dementia educators who, because I can't be in multiple places at once, I don't think people want that, but then we can equip other educators in offering this education.
Thank you. The next question is about diagnosis. So you mentioned that you can go if you're experiencing symptoms or if one of your family members is experiencing symptoms, so important to go to your doctor. But can you talk a little bit more about a way that a doctor can reliably diagnose dementia? For example, would you start with your primary care physician or how would that really work?
Mm-hmm. So in today's landscape, our message is anyone over age 65 should be having an annual screening at their annual wellness visit. The screening is a simple tool that assesses for the loss of cognitive functioning. So it would detect, oh, something's wrong. Now, what we're also finding is not all providers are doing that on a routine basis. So sometimes people have to request that, but we are encouraging people to request that earlier rather than just when it is so obvious it needs to be done, and the score would be much lower. First step, advocating for that with your doctor or your loved one's doctor. A doctor might not be able to talk to you. You can always phone a doctor and leave a message to say, I am concerned about my mom. Can you please do this? That simply detects that there is something going on, such as some sort of cognitive impairment. It would then be up to that doctor to do a variety of steps after that. That up until recently has kind of been ruling out other things, doing some blood work, doing an MRI or CAT scan, screening for depression, a sleep apnea test. They're going to do a variety of tests to see, could something be going on that could be causing this cognitive change, such as maybe there's some untreated diabetes. Now, if a doctor has done all of those things and the person is otherwise healthy and fine, that's often when we're seeing a referral to someone like a neurologist or a neuropsychiatrist who can do, let's call it, two buckets of things. The first, they might be able to do additional neuropsychiatric testing that is much longer. It's a few hours. It's much longer than that simple screening that's done in the doctor. And then the second thing that they can do is use some of these diagnostic tools, such as cerebral spinal fluid tap, PET scan, maybe a blood test in future years, to confirm, because all this other stuff is being ruled out. The neuropsych testing said, yep, this is kind of what's going on functionally. Then let's look at these diagnostic tools to see if Alzheimer's disease is present, to confirm that that is in fact what's causing the changes. So a lot of people think, oh, I just need to start with step one, see a neurologist. And in today's landscape of care, the conversation instead is, you may need to see a neurologist eventually, but start by addressing your brain health with your doctor, even if you don't have symptoms. Do this testing as kind of a part of your annual preventative or annual screening appointment.
Thank you, Kelly. There's another great question that I really want to get to, but we're bumping right up against time, which is about the stigma and how do we talk about this and how do we get this out. I think it just goes to show that this is a very rich and a very important topic. So thank you so much for being here and for talking with us about this. If you would like to stay connected, Kelly has very cleverly put her email address in her right in her name, and I'm going to do the same thing and just add my email address. So if you'd like to connect to talk more about this topic or to see if maybe you would like to help to disseminate this information, and we can talk about also curating it for the different populations that you might be working with, then by all means, please reach out. And thank you all for being here. This will be recorded. I'll let everybody know how they can access the recording and the slides afterwards. And I hope you have a very wonderful rest of your afternoon. Thank you very much.
Thanks, Amy. Take care, y'all. Thank you.